afternoon. I thank my colleague Pauline Vetter, who works on this presentation but was finally not available today. I'm pleased to talk about Ebola survivors, as they have been quite neglected before this epidemic, which drastically increased their number. I will present brief facts about the actual knowledge regarding survivor and share some observation we've done in the MSF Survivor Clinic in Freetown, where we both had the opportunity to work. I have no conflict of interest. Let's start with some epidemiologic data from WHO on the 3rd of June. There were approximately 27,000 infected cases with 11,000 deaths. That implies that there are more than 10,000 survivors in West Africa. The most touched country was Sierra Leone, followed by Liberia, then Guinea. In Sierra Leone, we have 4,000 survivors, with 1/4 in Western area. We can see also on this graph that the peak of the epidemic was between October and January, and presently there are around 10 cases per week in Freetown, for example. As mentioned before, there is little knowledge about survivors, even though this disease appeared 39 years ago. As of June 12, there were 13 studies only. It is well established, though, that survivors barely directly go back to their pre-disease functional status. Pain, weakness, fatigue are the main complaints. So a certificate of discharge doesn't mean complete cure. There is no electronic database for survivor, so this is the only proof of their survivor status. It's a valuable paper because they can get some free care, they can work in ETC or as health promoter with this certificate. There are some locals who made some fake certificate and worked in risk zone and then died because of contamination. In the survivor clinic, it was a limiting factor because we had to verify them, which was really time-consuming and complicated by the limited collaboration between different ETC. So patients are discharged from ETC when they have one negative blood PCR, no more acutely symptomatic, and autonomous. However, the virus persists longer in different body fluids. For joint and cerebrospinal fluid, we have no idea. For semen, it can be cultivated up to 82 days. And PCR is positive for 199 days. In the aqueous humor, it's positive until 10 weeks. All this data highlights that there is still IPC issues after discharge. It raised the question, is Ebola a sexually transmitted disease? We can talk about the case of a woman who was infected in Liberia 30 days after the last case. Her only risk factor was sexual intercourse with a survivor who was shedding some Ebola RNA in his semen. Although complete genome sequencing has not been possible from the semen, available data match the sequence obtained from the plasma of the infected woman. Moreover, none of the mutation retrieved in the seminal isolate sequence were observed in 22 isolates from systematic analysis conducted since January 2015 in Liberia. increasing the likelihood that this latest infection was through sexual transmission. At discharge from ETC and at the clinic, condoms were given with the advice to use them until further notice. Here is a review of post-Ebola syndrome symptoms. Arthralgia and myalgia are really frequent, concerning 50% of survivors and with functional repercussion. I think of fishermen or building constructor survivor who couldn't work after the disease. They can complain of itching eyes, blurred vision, retroorbital pain, with uveitis and conjunctivitis diagnosed. They complain of short memory loss, headache, are often depressed. They have hair loss, hearing loss rarely. Less frequently, there is cardiac involvement with myopericarditis, tachycardia, possibly in relationship with a thyroiditis. Upon the skin, we can see rashes and desquamation, the second phenomenon being more frequent if there was a rash during the acute phase. Here is a table summarizing the studies done about ocular finding, putting into light that uveitis is a common complication in around 25% of cases, a number that was confirmed in the file. Uveitis can be anterior, posterior, or global, and they require steroid treatment in order to prevent blindness. We've seen 2 young survivors in the clinic who developed unilateral blindness due to rapidly progressing cataract. Unfortunately, due to IPC reason, surgery was not safe at this moment. The MSF survivor clinic of Prince of Wales opened beginning of February on the same location of the ETC. We have been following a total of 162 survivors coming from 12 different ETC. They came every 1 or 2 weeks with at each appointment 1 medical consultation and 1 mental health consultation. During medical consultation, vision was assessed with referral to eye clinic if needed, prevention about STD, proposed HIV screening with 75 negative results and no positive results. And we treated some intercurring infection, mostly from the skin, genital tract, lungs, and malaria. Then they were seen by a local psychologist who did a questionnaire, personal counseling, like learning some exercise to relax, and group discussion or family support. Local health promoters were also implicated, going into the survivor community when there were some stigmatization issues. That was frequent. On the EPC side, we were wearing scrubs and gloves with light PPE if urine testing or genital examination. This is the table of the symptoms at first visit. We see that eye complications are really frequent, joint pain, hair loss. As already said, on the eye side, uveitis are quite frequent, with almost 60% of the referred case presenting this diagnosis in our cohort. The other is mostly conjunctivitis. So we can consider that there are three kinds of complications after Ebola disease. First physical, second psychological, and third social. The two latest worsening usually the first. That is why the holistic approach established in the survivor clinic was really adapted. Unfortunately, in West African countries, there is a huge lack of healthcare professionals. Therefore, NGOs are required for assistance even after the epidemic. This is the result from the mental health consultation. We can see that survivors are sad, more worried, cry easily, and have concentration disorders. The pathogenesis of post-Ebola syndrome is still unknown at the moment. Is it the persistence of the virus or virus antigen in protected body compartment? Is it immune complex deposition, like with chikungunya or dengue virus? Studies show that the IgG titers is higher in survivors with arthralgia, and that there is a persistent activation of T cells up to 2 months in two severe survivor cases, but not in two mild cases. Sequelae are more frequent if seizures and melena were present during the acute phase. In conclusion, there is a high prevalence of eye problem and arthralgia, and we should not disregard the psychological issues following a near-death experience and long painful recovery exacerbated by socio-economic burden. So we still need to learn more about the virus pathogenesis and shedding in order to treat survivors and limit the possible late transmission. I want to thank, with Pauline, all the survivors, Professor Laurent Kayser, Dr. Manuel Schibler, all the MSF team, Dr. Olivier Agon, HUG director, who made this collaboration between HUG and MSF possible. We will finish with some picture of the survivor and in music with the song written and sung by a 12-year-old survivor at the clinic.
If I don't pack and I street, do you not laugh me? If I don't play with my friends, Thank you so much.